Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, welcome everyone. We have a very exciting and special session today, and on behalf of myself and the entire team, we'd like to welcome Dr. Joel Gallant from Santa Fe, New Mexico. Dr. Gallant is one of the world's leading HIV clinicians and researchers. His accolades would take me the whole hour to go through, but suffice to say, Dr. Gallant is professor at University of New Mexico, adjunct professor at Johns Hopkins, and has led a lot of the pivotal ART and treatment studies, and has agreed to talk to us today about a very important topic, switching ART. So, Joel, thank you so much, and I will turn it over to you.
Thank you. It's a pleasure to be here. Welcome, greetings from the land of the original Echo, and a special shout out to Bellingham, where all my family lives except me. So, yeah, I'm going to talk about switching ART today. These are my disclosures, and these are the objectives. We're going to talk about, all right, so when and why would you switch therapy in a suppressed patient? And I have to preface this by saying that most of the time these days when we're switching, we are switching in suppressed patients. The issue of switching for failure and resistance has become much less common, thankfully. So these are some of the reasons that the guidelines give to manage side effects, to manage or prevent drug toxicity, and I think it's important to emphasize prevent. You don't have to wait for toxicity to switch. To simplify the regimen, to address food restrictions or drug interactions, or to plan for pregnancy. I always add two more personal reasons that they won't let me put on the list. One is to avoid embarrassment when your patients go somewhere and are found to be on a really weird old-fashioned regimen, and the other is to avoid boredom, since you don't want to spend the rest of your career just refilling the same regimens you've always been refilling. But those aren't official reasons. So I want to just start by talking about reasons to consider switching therapy in patients on older regimens. The guidelines are very clear that you don't need to switch someone just because they're not on a recommended regimen. There's a difference between treatment-naive patients and treatment-experienced patients, and it's okay to continue some regimens that may not be up to date. But you may want to consider it in some cases. With older PIs, you can usually reduce pill burden, decrease metabolic side effects, and decrease GI side effects with switches. I think with older nukes, there are definitely reasons to switch, and I would say there is no excuse for D4T or DDI anymore. Those should all be switched due to toxicity. And the fact that someone doesn't have toxicity now doesn't mean that they couldn't end up with lactic acidosis or hepatic steatosis at some point. I almost put AZT in that same category, but I didn't. But I do think that there's very little reason to use AZT anymore. Now, the real topical question is whether to switch everybody from TDF to TAF, and we'll talk about that. Right now, there are advantages of TAF with very few disadvantages, and in fact, not only is there no price difference, but Gilead cleverly increased the price of TDF to encourage these switches, so there actually may be a price advantage of TAF. I think with nevirapine, most of the toxicity is up front, and so people who've been on it for years are probably okay, but of course you could reduce pill burden. And efavirenz is sort of a maybe. We're learning more and more about long-term CNS side effects, including the 2 studies now showing an increased risk of suicidality even after years on therapy. And the other new reason to consider switching is that there is no TAF-based co-formulation with efavirenz, unlike with many of the other co-formulations. So even patients who've said they love efavirenz, I have brought this up more recently because of the issue of TAF. So let's talk first about one study involving a switch to dolutegravir, abacavir, lamivudine. This is the Striving study, and it was updated in Durban just a few weeks ago. Basically, people either stayed on their existing regimen or switched to this single tablet regimen right away or later. And the study was a little complicated because people got into the study who really shouldn't have been included. They had prior virologic failure, which they weren't supposed to have had. So although there was really no difference in virologic response, if you looked at an ITT analysis, in fact, there were more discontinuations in the switch arm. You didn't see that. So this is the delayed switch arm. These are the people randomized to switch after 24 weeks. Again, virologically, they did very well. But there were more discontinuations due to adverse events in those who switched early, not so much in those who switched late. But remember, with this particular regimen, many people are switching all 3 drugs at once. So they might have been on a TDF-based regimen with a protease inhibitor or a non-nuke and are switching, 3 drugs at once as opposed to one. And of course, every time, with every additional drug that you switch, you always do run that risk of more side effects. However, patient satisfaction was actually higher in those who switched, despite the side effects. And we saw fewer adverse events in the people with the late switch for reasons that really aren't entirely clear. You certainly are all aware of TAF by now, and the fact that TAF is another prodrug of tenofovir that gives you lower plasma levels and higher intracellular levels, and for that reason is thought to be less toxic, especially to bones and kidneys. Now, there are a lot of switch studies, and if I were to go through them all, it would take the whole hour. I'll just try to summarize them and then present one. So there's the 109 study, which was various TDF-containing regimens switching to ECF-TAF. There was the 112 study switching to ECF-TAF in patients with impaired renal function, and the 1089 study, which was FTC-TDF to FTC-TAF. And to kind of summarize the results of all these studies, they pretty much all show non-inferiority with the switch. And in fact, in the 109 study, if you were switching from efavirenz or boosted atazanavir, they actually found superiority with the switch. You almost always see increase in bone density and possibly back to baseline, although I don't think we've established whether that's the case yet. And you generally see stability of the renal function, and in fact an increase in eGFR in the 1089 study with no tubular toxicity and generally a decrease in overall proteinuria and tubular proteinuria. So I'll show just one example. Here's the 1089 study that I presented this summer in Boston at the ASM meeting. And you can see very little virologic failure in those who stayed or switched, and no significant difference between the two arms from an efficacy standpoint. More importantly, though, if you look at changes in estimated GFR, you do see a benefit with the switch. So at the end of 48 weeks, for the most part, people remaining on TDF had fairly stable renal function, but those who switched had an increase in estimated GFR. And here are the urine protein to creatinine ratios. And you can see that, interestingly, even though the people on TDF had been on TDF sometimes for years, they were still seeing an increase in proteinuria over time. And this includes both overall and tubular proteinuria, whereas when they switched, then you saw a decline in proteinuria. Now, these are not necessarily clinically significant levels of proteinuria, but it does suggest that over the long term, there may be a renal benefit to TAF. Then, of course, the bone density, as you would expect, people on TDF have already experienced their loss in bone density back when they first started, so it's not surprising that their bone density levels are flat at this point over the year. But if they switch to TAF, you see a rise in bone density that continues through 48 weeks. It's a small amount, but there may be continued bone density increases after that time. And there was a significantly smaller proportion of patients in the TAF arm who had a 3% or more bone density increase at week 48. So that's kind of a characteristic of what we see with various TAF studies. I do want to mention one that's a little different, and that's GS119. This was in treatment-experienced patients with drug resistance who had had prior virologic failure, and they were randomized to stay on their current regimen or switch to a 2-pill combination of ECF-TAF plus 800 milligrams of darunavir. Now, the caveats here, they could not have integrase mutations, or they had to be on raltegravir with an undetectable viral load. They could not have more than 3 TAMs, and they could not have any darunavir mutations, so that once daily darunavir was appropriate for them. And you can see here, I won't go through all the demographics, but about 40% were on at least 6 pills per day. The median number of pills per day was 5, so there was a significant decrease in the number of pills that they were taking. So here are the results, and at week 48, the switch was actually superior to continuing current therapy, not just in terms of the no data category, which includes dropouts and discontinuations for toxicity, but in fact, it was significantly better in terms of treatment failure. There was no resistance in the switch arm. One participant with a rebound in the baseline regimen arm did develop resistance. So this is an option for many people who are treatment experienced, but not all of them. And I think it's important to remember the resistance criteria for this study so that you don't overgeneralize it to all of your so-called salvage patients. So what about even simpler regimens? So people are now looking a lot at things like two-drug regimens and induction maintenance approaches. Why are we looking at two-drug regimens? Well, for a long time, the concern was nucleoside toxicity. There was the kidney and bone toxicity of TDF. There was the potential cardiac toxicity of abacavir. And so people were looking at ways to get around that by not using either of them. Cost, of course, was an issue, and we've seen a lot of studies of things like 3TC plus a second agent being studied in settings where resources are a little bit limited and they can reduce costs that way. And then the third reason is to allow for long-acting therapy, and the example that I'll show is the cabotegravir-rilpivirine example. I put avoiding nucleoside toxicity in parentheses because it doesn't seem like a real compelling rationale anymore now that we have TAF. There are really extremely few patients who can't take one of those three nucleosides, TAF, abacavir, or TDF at this point. So in Durban, we saw further results from the LATE-2 study. Remember, this is an induction maintenance approach where people start on a standard three-drug regimen and then switch to either oral cabotegravir and rilpivirine or injections. One arm gets every 4-week injections, one arm gets every 8-week injections. Remember, cabotegravir is a integrase inhibitor somewhat related to dolutegravir, and rilpivirine is a long-acting version of the rilpivirine that we use as an NNRTI. And you can see overall the results look quite good in all three of the arms through week 48. Here are the virologic outcomes. Now, I would point out that there was a little bit of a problem with the 8-week dosing. You can see a little bit higher virologic non-response in that arm compared to the oral and the Q4-week arm. And in fact, there were 2 subjects with resistance in that arm, the 8-week arm, one with integrase mutations and one with non-nucleoside mutations. We have not yet seen integrase mutations with dolutegravir, but that has not been the case with its cousin cabotegravir, where you can get mutations. So my understanding is what the company is going to do now is although they're going to continue the Q8-week dosing in the existing patients, their plan for the phase 3 study is to study a monthly injection as opposed to trying to spread it out to every 8 weeks. And just as a tangent, when they looked at using Q3 month dosing for PrEP, that didn't work out so well from a PK standpoint. So there's definitely a limit to how much you can push this long-acting therapy with this particular combination. So the issue with induction maintenance is kind of interesting because some studies and some companies choose to study their regimens with 2-drug regimens, and examples there would be the boosted PI plus 3TC studies, the dolutegravir plus 3TC studies, where everybody just starts out that way. They don't start on a full 3-drug regimen and then switch. They just start with a 2-drug regimen. And we have quite a lot of data of those in that kind of study. Other companies choose to use an induction maintenance approach where you start with standard therapy and then switch. And the examples there include the LATE studies that I just showed and some other 2-drug studies. So the question really is, why would you pick one over the other? Do you need induction? Would a 2-drug maintenance regimen have worked just as well from the start? And unfortunately, the only thing we can ever know is how they study the regimen. You don't, in the case of LATE, for example, you don't know what would have happened if you had started with cabotegravir and rilpivirine from the outset. So what we eventually do in clinical practice will probably depend on the study design. I haven't really talked about the data on things like dolutegravir, lamivudine. You all know that it's out there, that people are excited about it, but it really has only been studied in 20 patients so far. And in Durban, we learned that one of those patients, 1 out of 20, did develop unexplained virologic failure so far without known resistance. So be very, very cautious about this. It's not a bandwagon we should be jumping on yet until we see more mature data. So, if to really give a switch lecture, you've got a lot of studies you can discuss, and it gets pretty boring because, for the most part, switches work when they're done appropriately. And I've just kind of summarized this, adapting it from a slide that David Wall made, summarizing a whole bunch of switch studies. And you can see on the right, the little check mark means that the switch worked, that the second regimen was at least non-inferior to the first. There are 2 exceptions that I can think of. One is harness, and it was a switch to the boosted atazanavir and raltegravir, whenever we see these studies of boosted PIs plus integrase inhibitors, there's almost always something that doesn't quite work out well, whether it's starting from scratch or switching, and we don't really know the reason, but that study didn't work out so well. More importantly, though, I think is the SwitchMerc study. It's an old study, but I think it holds a lot of lessons for this question of switching. So just to remind you, the switch study from years ago, this was a study where people were randomized to either stay on a lopinavir-ritonavir-based regimen or switch to raltegravir with continuation of their nucleoside analogs. And the important thing about this study is it didn't matter what their treatment history was. They could enroll in this study despite multiple previous regimens, virologic failure, resistance, etc. And you can see that in those who had previous virologic failure, switching to raltegravir didn't work out so well. There was higher rates of failure than remaining on lopinavir-ritonavir. And I think even though that study is old, we should never really forget it, because it reminds us that we have to still be intelligent about our switches and can't just make them because there's something shiny and new that looks good. So the caveats with switching are that you got to know the treatment and resistance history of your patient. That's easy if they're on their first regimen. You don't need to know very much other than their baseline resistance results. But it's more complicated in the patients who have been treated for many years and have been on multiple regimens. And when you don't know that history, when you don't have the old resistance tests and the old records, I think you really need to avoid switching from high barrier to lower barrier agents, which is what they did with the SwitchMerc study. So this is a tool that may be helpful in these situations. We get lots of people in Santa Fe who 68-year-old men who retire here having been HIV positive since the late 80s and have had 6 or 7 doctors, and no way you're going to get those old records. This is like not a substitute for old records, but it may be the next best thing when you can't get them. It's a proviral DNA genotype that's now commercially available, and we saw data a year ago at ICAC showing that the false omission rate, meaning that the test failed to pick up resistance mutations that were known to be present from historical genotypes, was only about 3%. Now, I've ordered this test many times, and I have to say, I think I've seen false omission rates of more than 3% in my own experience. So you have to take these results with a grain of salt. And if they don't make sense to you, if somebody comes in who's had a history of multiple virologic failures and has a wild type archive genotype, you should toss it or shred it to be HIPAA compliant. But it may help you at times when you're trying to find out, do they have darunavir mutations? How many TAMs do they have? Are they candidates for the 119 regimen that I discussed? Then it can be helpful as long as you're analyzing it carefully. So I want to close by just kind of dividing up switches into what I call horizontal switches. These are the so-called no-brainers where you really don't need to know much because you're not reducing the resistance barrier. Examples: going from a ritonavir booster to a Kobe booster, going from raltegravir, elvitegravir to dolutegravir, going from a first-generation non-nuke to a second-generation, going from TDF to TAF, etc. It's pretty hard to imagine you're going to get in trouble from a resistance standpoint with any of those switches. The switches that do require a brain are the vertical switches, where you're reducing the resistance barrier, and that would include most discontinuations of drugs, switching from boosted PIs to just about anything else, with the possible exception of dolutegravir, which may have a resistance barrier as high as a boosted PI, or going from twice-daily darunavir to once-daily darunavir. Those are the switches where I think you really got to have some data before you make them. So with that, I will stop. I understand you guys have some great and relevant cases that touch on these issues, but I'd be happy to take questions.